my talk is rather a warming up for this mega discussion about the glenohumeral instability. I'm Erica from Indonesia. Let's start. Okay, shoulder instability is a very long recognized problem since the description of this method of shoulder reduction by Hippocrates. Despite this long-standing problem, I feel that the definition and consensus of the classification is not clear. As the result, there is a long winding debate regarding the management. For example, let's take a look at this. Different authors define instability in different ways. Even in the same textbook, the blue arrow represents the textbook from Dr. Madsen. But at least we can see 4 different definitions of glenohumeral instability. And here is the other textbook by Dr. Warren, same publisher, but 2 different instability definitions. I think to avoid confusion, the definition should be very clear, accepted universally by me and you and others, before the disorder can be classified. When we look at a patient who's suspected to have a shoulder instability, pain as a symptom may always confuses me, at least how to make a diagnosis. For example, if I ask myself, does the patient with a painful labral tear have instability? And does this thrower patient with shoulder pain, but he got no sense of abnormal glenohumeral joint, have a subtle instability? Okay, and as there are many disorders in the shoulder capable of producing pain, I think pain should not be used as a symptom to define instability, but a clear definition of instability would be one where patients have a sensation of their shoulder as loose, going out, or slipping. I admire Dr. Charles Neer, of course. He is a pope in shoulder surgery. Historically, but the medical literature regarding the instability has a number of flaws. First, most studies in the literature up until now is the procedure-based, not a condition-based. As a very popular example is the landmark study in 1980 by Dr. Neer on MDI. In that study, Dr. Neer included patients with different features of instability. Yet, the patient had one common procedure, the inferior capsular shift. When a paper is a procedure-based, it may include so many different populations who receive one same treatment. Instead, papers should be condition-based, which with the same population with a specific well-defined constellation of features is collected. And let's say 2 or 3 treatments are compared. As a result, I become more confused, and I think some of us perhaps may have this confusement. We do not have a clear definitions of glenohumeral joint instability in the literature, and the papers tend to use a potpourri of descriptive terms, which unfortunately are well received by most of us. These problems lead to the heterogeneity in the literature, making comparisons of different treatments difficult and meta-analysis nearly impossible. Because of the wide variation in the definition of the MDI of the shoulder in the literature, there is a wake-up call article in the JBJS aiming to decide if this variation influenced the distribution of diagnosis in a cohort of patients with shoulder instability. Dr. McFarlane used 4 classifications. I think these are popular to classify this cohort with the MDI and adding a laxity test as a criterion for diagnosing patients. The study demonstrated that the variations in the criteria used for the diagnosis of MDI significantly affect the distribution of the patients with the diagnosis. So when you use a laxity test, it tends to overestimate the number of MDI. This observation is important because the results of the studies may vary if the patients with traumatic instability are considered to have MDI just because of the positive laxity testing. So until the criteria is clear, investigators or researchers will not be able to contribute in a compelling way to understand the condition, since they cannot know whether studies are comparing apples and oranges. Let us remember some popular definitions regarding instability. Sulcus sign, very popular, is a dimple created beneath the acromion when the subject's arm is actually traction down, usually in a seated position. This is very popular as a hallmark test for MDI by Dr. Neer. Although Dr. Neer reported that all of his patients had symptoms of instability with the sulcus sign, it is many of us now interpret a positive sulcus sign with or without symptoms only as a sign of inferior instability. It doesn't mean the patient have MDI. Another very popular definition in 1987, the dead arm syndrome by Dr. Carter Rowe. Looking at his paper, many of his patients were aware that their arm were slipping, others were not. But Dr. Rowe considered all of those patients to have instability and performed an instability surgery to treat them. This picture is very typical, showing a very typical position for elevation and external rotation in which the arm goes dead. However, many of Dr. Rowe's patients had signs and symptoms for bursitis, biceps tendinitis, nerve impingement, cervical spine refer pain, and thoracic outlet syndromes. As such, it is not clear if this patient really have instability. So coming back to the definition, I think we have to have two common themes in the definition, which are symptoms and translation. Because we know that many patients have symptoms, especially pain, without instability. We also know that laxity tests can be existed in many patients without symptoms, and some can sublux their shoulder without any symptoms. Therefore, these two elements have to be together to define instability. Patients must have discomfort and feeling of loose, slipping, or shoulder going out to meet the definition of instability. A good classification should be simple, easy to use, accurately describe the different types of instability, reliable, reflect patients' perception of the disorder, and predict natural history and maybe possible treatment. This is a systematic review, identified 18 different proposed classification of the glenohumeral instability. Yes, we have 18, which use different criteria. The frequency with which different features are used is presented. So far, we have etiology, direction, severity, and frequency as the most commonly used features. And Dr. Kuhn in 2011 introduced this system, the acronym FATS, to classify the glenohumeral instability, which later developed as a classification that can predict the likelihood of having surgery and perhaps to provide a prognostic insight. The FATS use the patient-reported outcome as a criteria for diagnosis. Frequency is an indirect measure of severity of the pathology, can be solitary, occasional, and frequent in a year. Etiology is also derived from history, can be traumatic or atraumatic. The formally described microtraumatic instability will be classified as a traumatic subclass. Patient also may be able to tell you the direction of their instability or which position of the arm will reproduce their symptoms. For example, hand behind head for anterior or carrying a briefcase for inferior. Provocative tests will be performed if patient cannot tell the direction. Severity is determined by history. If a patient never has to require assistance to have their shoulder reduced, they will fall under the subluxation subclass. The classification had a good inter-observer agreement because I think it is highly dependent on the history and perception of the patient. Unlike the physician-derived criteria, which highly depends on the examiner skill. Okay, this is the example of the flow of the FATS classification. So while it is very extremely useful and easy to utilize, the classification does not really direct us to the appropriate treatment. So this is the MRI of 3 different patients with the same age, 17 years old, suffer from a first-time dislocator that were able to be reduced by the first trial. The first patient is not a professional athlete. The second and third patient are the professional athletes. If I use the FATS system to classify this instability, it means solitary, traumatic, anterior, and dislocation. They have the same classification. However, most of us, or at least us, will recognize that each case should be treated differently. Perhaps I will vote case A to be likely to improve with therapy. Case B might need a labral repair. Case C might need a glenoid reconstruction. So in light of this reason, the anatomic lesion should always be considered in the current classification. Take-home messages is we should involve academic institutions and subspecialty societies as the logical groups and to bring the relevant stakeholders together to develop such consensus for discussion, ratification, and validation of this topic. I think this is my topic. Back to you, Dr. Daniel.